Good evening everyone. Today we'll be discussing about a case. 80-year-old male patient presented with the complaints of irrelevant speech since 10 days, fecal incontinence since 15 days and urinary incontinence since 2 months. MRI brain was done. This is an axial T1 weighted MR image showing a large heterogeneously hypointense lesion predominantly involving the white matter of right frontal region, genu of corpus callosum, crossing the midline and extending into the white matter of left frontal region. The lesion is causing mass effect in the form of effacement of bilateral frontal horns of lateral ventricles, and there is mild effacement of adjacent sulci noted on the right side. This lesion is heterogeneously hyperintense on T2 with few cystic spaces noted, and it is iso to hyperintense on flare with significant perilesional edema noted. This is sagittal T2 weighted MR image showing the lesion is involving genu and proximal body of corpus callosum, causing inferior displacement of lateral ventricles. And on coronal flare image, we can see the lesion is involving genu of corpus callosum and extending into the white matter of bilateral frontal regions with significant perilesional edema noted on the right frontal region. And on DWA, the lesion is showing very few foci of diffusion restriction which are low on ADC corresponding to blooming foci in SWA, suggesting that there is hemorrhage within the lesion. Further, MRI brain contrast was done. These are axial, coronal and sagittal T1 post-contrast images showing thick peripheral rind-like enhancing lesion with central non-enhancing areas of necrosis noted. Further MR spectroscopy was done which revealed choline peak, Na dip and lipid lactate peak. Differential diagnosis to be considered for this case are glioblastoma, CNS lymphoma, astrocytoma IDH mutant type, metastasis, brain abscess and tumefactive demyelination. The final diagnosis of the case is glioblastoma. Let's discuss about the classification of adult type diffuse gliomas. Adult type diffuse gliomas are classified based on IDH1 mutation by immunohistochemistry. If IDH1 mutation is present, then we will be checking for 1p19q codeletion status. If it is positive, then the diagnosis is oligodendroglioma. If it is negative, then the diagnosis is astrocytoma IDH mutant type. If IDH1 mutation by immunohistochemistry is negative, further we will be going for IDH1 and IDH2 sequencing. If it is still negative, then we will be checking for any one of the following features, which include necrosis, microvascular proliferation, TART promoter mutation, EGFR gene amplification, chromosome whole gain 7 or whole 10 loss. If at least one of the feature is present, then the diagnosis is glioblastoma IDH wild type. If none are present, alternative diagnosis should be considered. Glioblastomas are most common adult primary aggressive brain tumors. Age of onset is usually after 40 years and peak age is between 65 to 75 years. Male to female ratio is 3:2. Majority of glioblastomas are sporadic. Rarely they are related to prior radiation exposure. They can also occur as a part of rare inherited tumor syndromes such as p53 mutation related syndromes including NF1, Li-Fraumeni and Turcot syndromes. While reporting a case of glioblastoma, we should include morphology, that is size in 3 dimensions, presence and degree of central necrosis, non-enhancing tumor involving cortex, deep grey or white matter. Look at ADC for lower values. Relationships or involvement of eloquent areas, major white matter tracts, large vessels should be reported. Extensions across midline, into brainstem, subependymal spread and CSF dissemination should be reported. Treatment. Stoop protocol is a standard treatment of glioblastoma. It consists of radiotherapy and concomitant chemotherapy with temozolomide, an alkylating agent. Response assessment in neuro-oncology criteria, that is RANO criteria, is used to assess response to first-line treatment of glioblastoma. Now let's discuss about few differential diagnoses to our case. CNS lymphomas. Most common locations are frontoparietal white matter, periventricular regions, deep grey nuclei and corpus callosum. Primary CNS lymphoma subtypes are angiocentric lymphoma, lymphomatosis cerebri. This is an axial T1 post-contrast image showing intense homogeneously enhancing lesion located in the white matter of left frontal regions and genu of corpus callosum. And there is an abnormal deep depression located at the tumor margin and normal brain parenchyma, which is known as North sign, which is highly specific for CNS lymphoma, whereas it is absent in glioblastomas. Few more differentiating points include enhancement pattern, which is homogeneous in case of CNS lymphoma, and it is heterogeneous with thick peripheral ring-like enhancement and central areas of necrosis in case of glioblastomas. Relative cerebral blood volume is low in CNS lymphoma, whereas it is high in case of glioblastomas. Cerebral metastasis, one more close differential diagnosis to glioblastoma. However, the location is usually at the gravite matter junction and tends to be multifocal. One more differentiating point is relative cerebral blood volume in the adjacent edema, which is high in case of glioblastomas and low in case of cerebral metastasis. This is an axial T1 weighted MR image showing T1 isointense lesion with central hypointensity, and on flare that the lesion is isointense with central hypointensity and significant perilesional edema located in the left parieto-occipital lesion. And on coronal T1 post-contrast images, we can see the lesion is homogeneous enhancement with central dot of non-enhancement, giving it a classical sign known as bull's eye sign seen in case of cerebral metastasis. Cerebral abscess, one more close differential diagnosis to glioblastoma. Differentiating points include dual rim sign, which is classically seen in cerebral abscess in T2 weighted and SWA sequences. Outer low signal intensity rim is due to capsule, and the inner high signal intensity is due to granulation tissue. And on DWA, we see central diffusion restriction in cerebral abscess, which is absent in case of glioblastomas. And the disproportionate edema, which means the edema is significant and disproportionate to the size of the lesion, which is seen in cerebral abscess. And the enhancement pattern is usually thin, complete and regular enhancement with central non-enhancing areas. Tumefactive demyelination, also known as monofocal acute inflammatory demyelination, occurring in a middle-aged woman. And this is an axial T1 weighted MR image showing hypointense lesion located in the left frontoparietal region. The lesion is hyperintense on T2 with peripheral hypointensity, and on flare the lesion is showing suppression with significant perilesional edema. So lesion of similar characteristics is also located adjacent to it. And on DWA, peripheral rim of restriction is noted. And on T1 post-contrast images, we can see incomplete open ring enhancement with open ring facing towards the cortex, which is classically seen in case of tumefactive demyelination. Astrocytoma IDH mutant type. Differentiating points are T2 flare mismatch sign, which is classically seen in case of astrocytoma IDH mutant type. Here we can see the T2 hyperintense lesion located in the left frontal region. And on flare, we can see the lesion is showing incomplete suppression with peripheral hyperintense rim known as T2 flare mismatch sign, which is classically seen in case of astrocytoma IDH mutant type. Thank you all, and I would like to thank Dr. S. Naveen Kumar sir for providing me this opportunity through his channel RadVision SNK, which is providing in-depth knowledge in radiology, which is helpful for all radiologists across the country. Thank you.